I will explain relevant text this time.
Yes.
Okay. Okay.
Yes, sir.
See, okay. See, Enneking classification system is what is followed for both for benign and malignant tumors. Please remember this. Enneking classification system is a basis for benign and malignant bone tumors. Okay. How are benign classified? Latent, active, and aggressive. Okay.
Yes, sir.
Malignant is low grade, high grade. Third is metastatic. Metastatic. Okay. So we'll come to one by one. What is latent? Latent grade is which is very all benign tumors. Among the benign tumors, latent, active, and aggressive. Latent is very slowly growing benign tumor which has got a very good, very well defined margin. Okay, and it has got a very thick margin. Because it is slowly growing, nature is trying to prevent the growth of the bone. So that's why there is a very thick reaction, thick bony reaction from the host. So this is how you see in a latent bone tumor. Active is apparently little more aggressive as compared to latent. So you will see a thin reactive zone. This is reactive zone. Reactive zone. Please remember, this is not periosteal reaction. This is reactive zone in the tumor. In active, the thickness of this reactive zone is less. Thickness of this reactive zone is less. Okay. And
Yes,
please remember, in latent and active grade, nothing happens to the native cortex. This cortex is there, no? Nothing happens there. There is no expansion. There is no fracture. So that's why they are very well centered. You remember certain tumors which are eccentric and trying to expand the bone. Normal bone is expanded slowly. Don't confuse this for a periosteal reaction. It is trying to blow out a balloon. Normal balloon, if it is slowly blown out, it expands. Similarly, this cyst or benign tumor blows out or tries to blow out the cortex. This is in aggressive and active.
yes,
And
sir.
then in aggressive, there can be break in the cortex. There can be a break in the cortex. In latent, there will be no break in the cortex. Okay?
Yes, sir.
Clear? Okay.
Yes.
We'll come to low and high grade malignant. This is what I was mentioning. So latent are incidental finding. The patient comes with the trauma some 2 months back. Now he develops vague pain. You see an X-ray. There will be a lytic lesion in the bone. It is incidental. Intracapsular, asymptomatic. Thick rim of reactive bone, what I was mentioning. Bone is not expanded, Roshan. Okay?
Yes, sir.
Strength of the bone is not compromised. Strength of the bone is not compromised. The patient can be easily walking and doing everything. Only that he will develop on and off pain. No need of treatment most often. Example, best classical example for latent benign bone tumor is non-ossifying fibroma.
Yes, sir.
In active, as I was mentioning, it is symptomatic. It can lead to pathological fracture. Rim, I was mentioning, is thin. Thin reactive bone. Cortex is thinned and expanded. Remember this, it expands like a balloon. More commonly it is ABC. ABC is nothing but aneurysmal bone cyst. Treatment is in latent, you can neglect, you can observe them regularly. Sometimes it can disappear because it is not affecting the strength of the bone. ABC, you have to do curettage. It is apparently active and aggressive. Aggressive will come to aggressive type of benign bone tumors. Here, reactive bone margin, what we showed in latent is a thick latent, thin active, and in aggressive, this reactive zone can be broken. And there can be also break in the cortex. How do you differentiate? This goes on expanding to become one with the cortex and breaks. So there's a break in the reactive zone. There can be a break in the native cortex. Please remember that. And the best example is GCT, giant cell tumor.
Yes, sir.
Last time only I had mentioned about extended curettage. Extended curettage.
Yes.
Okay, marginal and wide excision is required in very aggressive giant cell tumor. So what is extended curettage? I just hope you remember. So
Sir, dry plus wet mopping, that is by the help of phenol chemical, most commonly used,
yeah,
sir. Destroy.
yes, yes. So you make a window here. You make a window here. You enter with a curette, and you clear all that. But there can be crevices. So you have to use adjuvant. Adjuvant can be chemotoxic or thermotoxic. Okay. So phenol is one such. Liquid nitrogen is one more. Hydrogen peroxide is also used. And we use PMMA. So what happens? It is clinically trying to extend the margin. So you curate here physically, but if you add some chemicals, the margin can be expanded. So these work by killing the remnant tumor cells. PMMA is nothing but also called as bone cement.
Bone cement, yes, sir.
Okay, if you can remember, it is very easy to remember. Polymethyl methacrylate. Okay, it has two monomers and polymer. There is one powder and liquid which is given separately to it is given separately. So on the table you mix, it forms a mass. It forms a mass like a dough, and you pack this entire cavity, remaining cavity. So it generates heat. It generates heat, and hence the margin here undergoes thermal necrosis. So there can be thermal necrosis of the normal bone as well as tumor cells. Please remember that. So what are the advantages of polymethyl methacrylate is it increases the margin of necrosis. So it helps in extended curettage. Third is it gives strength. It becomes a very, very rock solid, hard mass. So it becomes, it helps us to make the patient walk or do its activities regularly. So what is the disadvantage? This is non-biological. This is a non-biological material. So you may end up in removing this. One more advantage of this is if there is a recurrence, the margin can easily pick up in finding the recurrence. So other adjuvants, as I said, phenol, liquid nitrogen, and hydrogen peroxide. There's one more thing is cancellous bone graft. So earlier we used to put bone graft instead of cement Advantage with bone graft is it gets incorporated. It is body's own autograft. So it is body's own. If the tumor gets cured, the bone also gets covered and generated. But the disadvantage with bone graft is recurrence rate is 40%. Recurrence rate of curettage and bone graft for GCT is 40%. Whereas with polymethyl methacrylate, it is less than 10%. Okay, please remember this.
Yes, sir.
So I will again go back to, so malignant. Malignant is either, you remember, it is, huh?
Ill-defined margin, sir.
Yeah, ill-defined margin. That is radiological. So malignant is low grade, high grade, and third. We have only three. Your TNM staging in surgery is different. Please remember this. Of course, you can add that also, but it goes like this: 1, 2, and 3. So again, it is classified as 1A, 1B, 2A, 2B. Okay. A is intra-compartmental, inside the compartment. Please remember that. It is inside the compartment. So it can be T 0 or 1, M0, no metastasis, and node. There is no nodal or lymphatic spread in bone tumors. So we do not go into this TNM staging, unlike other sarcomas in your general surgery. But it is always in the form of 1 low grade intracompartmental, low grade extracompartmental, high grade intra and extracompartmental. Third is whether it is low grade or high grade. If it is already having metastasis at the time of presentation, it is third grade. Okay, I'll come to that later. Compartments. So one important thing you should remember is it is not the compartment what you see in hand. Say it is thenar compartment, hypothenar compartment, or flexor compartment, extensor compartment. That you do not get confused. Okay. So what are compartments? These are natural anatomical barriers to tumor growth. Please remember, thick fascia. Thick fascia is always offers some resistance for tumor bone growth. Remember this. So what are the normal compartments? You remember this. If there is a bone here with the cortex, this entire bone is one compartment. There can be a tumor starting here or anywhere. So this normal cortex with periosteum, entire bone is one compartment. If there is, say for example, there is again, for example, this tibia, this I was mentioning, if there is an intramedullary tumor or inside the bone. But if there is a cortex, which is a tumor in the cartilage, articular cartilage or facial cartilage. Please remember there is a difference. In mature bone, the end is covered by the hyaline cartilage. That is a articular cartilage. But in adolescent, there can be facial cartilage, epiphysis and facial cartilage. So this also in itself is a compartment. Okay. Then comes your fascia. Say suppose there is a tumor in quadriceps muscle. It is covered by thick fascia, which again connects it to linea aspera. So entire one muscle is compartment. Similarly, a joint capsule. I can give example for individual, but will cortical bone, say osteosarcoma, articular cartilage chondrosarcoma, facial septa limited, most commonly fibrosarcoma. Similarly, joint capsule can be synovial chondromatosis. Okay, then you will not follow if I say so quickly. So please remember, these are the anatomical barriers. If there is a tumor here, if it breaks and enters the soft tissue, it becomes extra compartmental. Okay, please remember this. So how do you differentiate low grade and high grade? Low grade and high grade differentiation is histopathologically. And how do you make out whether it has breached the compartment or not? It is by radiologically. MRI is a must. MRI of that part of the tumor is must to know whether it has become extra compartmental. It is very, very important. So what is important in the management of malignant tumor is intracompartmental or extra compartmental, low grade or high grade. Okay, that helps in deciding whether you want to save the limb or you have to do the amputation of the limb, or it is also limb sparing surgery or limb sacrificing surgery. So low grade, of course, it's the job of the pathologist. How do you differentiate histopathologically? Is very well differentiated. Poorly differentiated is high grade. Few mitotic figures in low grade, very high mitotic rate in high grade. Moderate cellular atypia. Atypical cells are less in number. And high cellular to matrix ratio means the entire in the slide, if you see, there's a lot of matrix, but it is highly cellular. The intercellular matrix is less and the number of cells are very, very high. Then it is high grade. So if you see a high grade in a histopathological biopsy examination, the chances of metastasis already is more than 25%. You should remember this. Okay, so how do you have to stage, then you have to grade. Staging is intracompartmental or extracompartmental, with metastasis or without metastasis. Grading is low grade and high grade. Okay, that is important because that gives us a insight for the management of a bone tumor. So what is 1A? Roshan.
The intracompartmental.
Yeah, low grade intracompartmental. So it is very clear. It is low grade and intracompartmental. So what you do? You do wide excision. You can save the limb. Okay, wide excision, you can save the limb. 1A is very, very good that you can save the limb. So what happens in 1B? It is low grade and extra compartmental. Okay, so once it has already gone, I talk of this staging with respect to osteosarcoma, at least to make you understand. Okay, it's the osteosarcoma, lower end femur, low grade, and it has already breached the periosteum. So it has become extra compartmental. So if there is a lower end femur tumor, it has breached the means already it has extended into quadriceps. So quadriceps attaches to lower end of tibia, and it starts from the different heads start from the acetabulum, all the four heads. So it can extend up to the periosteum. So what is compartment? Why you have to know that compartment is, if there is a very restricted to lower end femur, you can remove the entire femur. So the chance of leaving the tumor tissue is less. Once it becomes extra compartmental, it has gone into the muscle compartment. Muscle takes origin from one joint above and one joint below. So removing so much of the limb and replacing with prosthesis, chances are very, very less. So whether to save the limb or do the amputation. So how do you decide? It is a low grade. It is already become extra compartmental. Depends upon the amount of tumor tissue left after the excision. You operate, you remove the tumor, you see on the table, you can send it for fresh frozen. You can see the margin of the tumor excised, whether the malignant cells are left behind. So if you feel there's a lot of malignant cell left behind, you have to forego salvage and remove the limb. That is amputation. Again, there is one more important thing is nowadays we are giving neoadjuvant chemotherapy. I'll come to that later. So two is high grade. High grade means they are aggressive. Before they come to you, they usually are extra compartmental. And the chances of skip meds within the bone are very high. So they are not amenable for saving the limb. They generally end up with amputation. One important thing is if bone tumors are responsive to chemo, one which we are thinking of amputation by looking at radiology, it has become extra compartmental. You have done core needle biopsy and it is high grade extra compartmental. But you do chemotherapy 4 to 6 weeks prior to surgery. If you see regression in the size, you can downsize or downgrade the staging and try to save the limb. Instead of doing radical excision or radical amputation, you can do wide excision. That is important. So margins I will explain to you with a diagram. I'll come to that later. Stage 3 means already if you at the time of the diagnosis, if there are distant mets, distant can be bony mets or it can be pulmonary mets. So that's why whenever you are doing evaluation of a bone tumor, you do chest CT to look for the small metastasis and bone scan. Bone malignancies are known to spread to different bones, hence you do bone scan. So with what you do, how do you treat the patient with stage 3 is if they are chemo responsive, you try and do amputation, save the life. For spare, you can sacrifice the limb, but you save the life. If it is not possible, do only palliative resection and take care of quality of life. Okay. So what are the goals of tumor management? Primary tumor, make patient disease free. Metastatic bone tumor, you know the patient is not going to survive for long. Reduce the bone pain, preserve the function. If there is a metastasis in proximal femur, he comes with a, say, suppose he is a patient of a CA breast, she comes with a femur fracture. So what you do? You reduce the pain. How do you reduce the pain? You fix the fracture and make her walk early. And simultaneously you treat the CA breast. So here you are not trying to prolong the survival duration of the patient. You are trying to improve the quality of the life by preserving function and reducing the bone pain. But in primary bone tumor, try and achieve making patient disease free. Up to 70% of osteosarcoma, long-term survival chances are there in low-grade osteosarcoma without mets. If they come with metastasis, the chances drops very much. It comes to less than 25 to 50% for the long-term survival, long-term disease-free survival. So optimal treatment of malignancies can be any of these three. Okay, surgery, chemo. This is known in any malignant tumor management. Okay, so I will come to radiation therapy in very brief version. Okay, how many of them have joined the class? How many are there?
Around 4-5.
Okay, great. Okay, I guess others are following. I just am taking Roshan name because he joined the class early. No hard feelings for the rest of them. Okay, radiation therapy is, most important. See, these whatever things I have highlighted, these are generally the MCQ questions. Most primary bone tumors are radioresistant. Please remember this. So you have to manage bone tumor, primary malignant bone tumor, either by surgery or chemotherapy. Remember this. Most of them are radio-resistant. There are exceptions. I'll come to that. Exceptions are marrow cell tumor. So you know what are the marrow cell tumor? It can be multiple myeloma, Ewing sarcoma, and lymphoma. These arise from the bone marrow. These are radio sensitive. You know, Ewing sarcoma melts like a butter with radiation. So most of the primary bone tumors are radio resistant, except from those arising from bone marrow. And metastasis of bone behave depending upon how their primary tumor is. Okay. You see a breast has spread to the pathology, causes pathological fracture. How see a breast behaves? Accordingly, its met also behave. So carcinoma metastatic to bone are radiosensitive. So I am coming to that. Please reinforce once again. All primary bone tumors are radio-resistant except for those arising from marrow. So what happens about the metastasis? Metastasis generally come carcinoma. Carcinoma from elsewhere comes to the bone mets. They are sensitive. Again, the exception is RCC. I guess you have to note down and please remember this. It's very, very easy, and this invariably appears in some of the other MCQs. So what is the generalized protocol for radiotherapies? 150 to 200 centigrade per day is the dose. And what is the target dose? 30 to 40 gray. Remember, 100 centigrade is 1 gray. So they give 5 days a week. 2 days holiday. And that's why they give about 42 radiation, 36 radiation. So you might be knowing some of your distant relatives, but somebody undergoing radiation therapy. You should try to understand this. So the maximum permitted dose is 150 to 200 centigrade per day, and you reach the target dose 30 to 40 gray. Again, that more fine tuning of the dosage is a super specialty thing. You don't get into that. This is what a basic thing what you should understand. So myeloma is less, and soft tissue sarcoma up to 60 gray can be given. Never give radiation for benign lesions. Remember this, because except in giant cell tumor. Giant cell tumor, you know very well, it is always treated by curettage or extended curettage with neoadjuvants and fill the gap with the bone graft. But if there is a very big GCT in the sacrum, very big GCT in the pelvis, where it is surgically inaccessible, you are not being able to do justice by doing curettage. There you would use radiation. In non-accessible large giant cell tumor, where if you remove a lot of curettage, you will have to make the spine unstable, and extended pigmented villonodular lesions. So radiation therapy side effects I will just mention. Acute, of course, there can be GI disturbance, urinary anorexia, pathological fracture, and osteonecrosis. Most important is chronic or late complication is radiation-induced sarcoma. Radiation-induced sarcoma is generally after 10 years of the patient survival after the radiation. So when is this possible? Especially in childhood malignancy. Childhood malignancy like retinoblastoma and other childhood malignancy, if they are cured by radiation and they survive beyond 10 years, there is a risk for radiation sarcoma. Please remember this. It has appeared in some questions also. So average lag 10 years post-op survivors can develop something called as radiation-induced sarcoma. And it is most commonly, it is osteosarcoma, and the prognosis is very, very poor. So please make a note if you can. radio-resistant bone tumors. As I said, all the tumors are radio-resistant. All bone tumors. Look at so don't try to remember this. Type of the tissue, cartilage, sarcoma, osteosarcoma. That is again bone, cartilage, bone, fat, sarcoma, fibrosarcoma. Remember all the tissues and add sarcoma for that. Rhabdo is muscle sarcoma. Synovium, so all the muscle tissues, if you can recollect, you can know it is they are radio resistant. And metastatic renal cell carcinoma. All carcinoma metastasis to the bone are radio sensitive except for RCC. I mentioned that. So one more modality of management after radiotherapy is chemotherapy. What is chemotherapy? Can be given in two ways: adjuvant or neoadjuvant. Adjuvant is after the surgery.
Yes, sir.
Neoadjuvant is before the surgery. Okay. What is the advantage? There are definite advantage of giving chemotherapy before the definitive surgery. So you do biopsy, you take histopathological examination tissue and start neoadjuvant chemotherapy. And what are the advantages? So once you give chemotherapy, neoadjuvant chemotherapy, and you exercise, you look for the imaging. You take MRI once again. If it regresses in the size, there are chances that it reduces in the size. It becomes less vascular. Okay, the
Yes,
grade
sir.
doesn't, and that which was the tumor which was for amputation can become a limb sparing surgery. So all this helps. And one more most important thing is you see the necrosis. Once you remove the tumor during the surgery, you see the necrosis in the histopathology. If it is extensively necrosed, means it is very, very sensitive for the chemotherapy drugs what you have given. You can continue that and the survival is very, very high. It is kind of culture sensitivity, like culture sensitivity. So you start chemo, after the biopsy, you remove the tumor, send for the histopathology, look for the amount of necrosis, lot of tumor necrosed, then it is very sensitive. Continue the same neoadjuvant drugs to adjuvant drugs. And it helps in downgrading. And one more important thing, all these are the advantages of neoadjuvant. So you have diagnosed the osteosarcoma, you feel it is a low grade, intracompartmental, you remove. So before harping, you give neoadjuvant. So what is the possibility? You have done CT scan of the chest, bone scan. There are no mets, but there can be still micrometastasis, which is not picked up by your scan. So those things, micrometastasis also can be taken care of by neoadjuvant. Micrometastasis can also be killed by the neoadjuvant. One more thing is during the surgery. During the surgery, when you are removing the mass, very likely that the margin is breached. Then you always remove the tumor with a normal tissue. But if there during the surgery with a scalpel or the cautery, you breach that. So there can be seeding of the tumor cells. Even that can be taken care by neoadjuvant. Please remember this. Neoadjuvant chemotherapy is very, very important for all these reasons. So it increases the survival of osteosarcoma patient by 70%. Chemo, no role in low-grade malignancy. Surgery is the mainstay in low-grade, slowly growing, cartilaginous. So bone malignancy are radio-resistant. They are also chemo-resistant. Low-grade are chemo-resistant. So what are the surgical therapy? Surgical therapy is, again, here I'll explain you the margins. As I mentioned, Roshan, that I wanted to explain the surgical margins.
Yes, sir.
This is what I was mentioning. So what are the margins? Whenever you remove the tumor, how much is the margin you have to remove is what you should know. Okay. So what are the margins? Intralesional, marginal, wide excision or radical excision. You have to remember this. There is no choice. So what are the surgical margins is intralesional, the spelling error, intralesional, marginal, wide and radical. Okay. So what do you mean by intralesional? This is what I was mentioning. Bone is one compartment. This is a extensor compartment of the knee or quadriceps compartment. There is a tumor here. These margins is applicable for excision or amputation. Please remember this. This intralesional, marginal, wide, radical margins is applicable both for excision of the tumor or for the amputation of the limb. Okay. In the transfer section, this is how it appears in longitudinal. Remember this. So this is a tumor. There is a reactive zone. Reactive zone is generally a soft tissue. This is a compartment. Intralesional excision. If you remove within the margin, so if you remove within the margin, this is the margin. So it is a marginal excision. You do the marginal excision. It is a intral. You gone into the lesion, isn't it? Red is a lesion. Red is a
Yes, sir.
tumor. You have gone into the. You have breached the pseudocapsule or the reactive zone. You have excised in the lesion. So it is intralesional. It is more commonly in benign tumors. Benign tumors. You do cure attack, isn't it? You are going into the tumor tissue. So it is intralesional excision. You are going in the tumor. So if you remove along with the reactive zone, it is a marginal excision. If you leave about 3 centimeter cuff, normal tissue, if you are going into a normal tissue, it is wide excision. All of you, please pay attention. This is very, very important. Okay. Intralesional, marginal, in wide and radical, you take a normal tissue along with the tumor. Wide, only 3 centimeter cuff is taken. In radical, it is entire compartment. Please remember this, entire compartment. I don't know whether you people can see this. This is what is important. The same margins which I was mentioning about during the excision, it is applicable for amputation also. Please remember this. You are removing the entire limb at in the lesion. It is intralesional amputation. It is debulking. If you are removing at the margins, marginal amputation, wide amputation, and radical amputation. Say suppose there is a osteosarcoma in the femur metaphysis. You have to remove the entire femur. This is one compartment. Removing entire femur doesn't mean amputation. Please remember this. You can remove the entire femur and replace it with a metallic femur. It is a limb sparing surgery. Mega processes is, if possible, you please remember. You are removing the entire compartment of the femur bone and replace it with a metallic femur. Okay, that is limb sparing surgery. This is limb sparing surgery. This is amputation. Some MCQs to avoid the monotony. Radioresistant bone tumor among the following are. Anybody? Huh? Hello? Huh?
Most radioresistant is osteosarcoma.
Osteosarcoma, very good. These are all arising from marrow. They are radiosensitive. I mentioned that. So some radiograph I wanted to show. I had shown even before also. I will highlight some. Nowadays, image-based questions are being asked. So this is sunburst newborn formation. Sunburst periosteal reaction, more classical in osteosarcoma. Why this is again sunburst or hair on end appearance. Why I have mentioned about this is, look at this. You look at this X-ray, you do not know how much is the tumor. So why it is important to take an MRI of that particular part is, you can see the entire tumor being extended here. You can see the entire tumor extended here. You can see this soft tissue also. It is already extending beyond the bone. Look at this. So MRI of the local part is essential during to make out whether it is intracompartmental or extracompartmental. This is one. This is one type of periosteal reaction as I was mentioning. You look at the bone destruction here. Can you see whether this bone is normal? You cannot make out, isn't it? This is a permeative bone destruction. You please remember this. In benign lesion, it is a geographical destruction. Permeative lesion, permeative destruction. You don't know which is normal, which is abnormal. See, you cannot make out normal pattern at all. Normal trabecular pattern is not seen. You don't know where abnormality starts and where it is normal. So it is a permeative. It is permeative means pervading, where you don't know which is normal and which is abnormal. Okay, please read this question.
Yes.
33 are present with slow growing bony mass along the distal femur cortex. In the metaphyseal region, there is a gap between the tumor and the cortex. Without a cortical invasion, usual treatment for them is
local resection.
Very good, very good. So many highlighting points are there. Slow growing tumor and no cortical invasion. So they are most are bone tumor, radio resistant. Chemotherapy you cannot consider unless they have given metastasis or other things. So now your choice is between local resection and amputation. So it has very well given that cortex in the there's a gap and without cortical invasion. So it is like something, if you can imagine, there's a bone which is like this, parosteal osteosarcoma. It is, if you can understand, slow growing tumor arising from distal femur cortex outside is parosteal osteosarcoma, and there is a gap here. So you can do a excision. Age group for osteosarcoma.
Second decade.
Okay. There's nothing given there. So 10 to 20 degree. Osteosarcoma occurs in easily, quick, very, very easy.
Osteoma.
No. See, certainly I think everybody will rule out these two things. Okay?
Yes.
So osteoma, you are left with osteoma and osteoitis deformans, also called as what? It is deforming, isn't it? Osteitis deformans, Paget's.
Okay.
If somebody has given a choice for Paget's, you will certainly go for Paget's, isn't it?
Yes,
Paget's is one of the reasons for secondary osteosarcoma. Normally, primary osteosarcoma is in second decade, 10 to 20 years. But if it appears in 40 years and above, it is secondary osteosarcoma. Paget's disease, primarily the patient will be having Paget's and he will develop osteosarcoma out of this Paget's. Osteoma is a benign tumor. Please remember this. It doesn't become malignant. Osteoma can be again from the skull. And yes, please differentiate between osteoid osteoma is different. Osteoid osteoma is different. Osteoma is seen in skull bones, and it is osteoid osteoma is very painful. Osteoma is not painful. It is a painless outgrowth or ingrowth. There can be seen in the sinus, maxillary sinus, inside the orbit, outside. It can grow out, but it is a very benign tumor, painless tumor. True about osteosarcoma, except
Sir, osteosarcoma is sir, metaphysis is the osteosarcoma, sir. Epiphysis is not.
yes, this is not wrong. It is metaphysis, most commonly knee and femur, hematogenous spread, sun reappearance. Very good, Roshan. Which is radioresistant? I think there is a repeat. So one more X-ray I wanted to show to impress upon the images. They will give such images, and they can also ask for a osteosarcoma. See, these are all sunburst appearance. Look at the geographical destruction, or sorry, permeative destruction. Look at this. The small lines highlighted here. This is onion peel, hallmark of Ewing sarcoma. Why onion peel appears is Ewing sarcoma, there will be in between growth arrest. It grows slowly, then aggressively. So intermittently, the periosteum is elevated and new bone is formed. So that's why it forms an onion peel appearance. All of the following about Ewing's are true, except
Sir, exarchoma is the most common in diaphysis.
Very good, very good. So metaphysis is osteosarcoma, diaphysis is Ewing sarcoma. Some highlights about chondrosarcoma. Please remember, chondrosarcoma appears in a elderly group above 40 or above 50 years, more common in pelvis. If you remember these images, you will easily recollect. Chondrosarcoma are radioresistant, they are slow growing tumor. You can see the matrix, they are bone matrix. You can have a popcorn calcification or a speckled calcification. These are all hallmarks, okay, of chondrosarcoma seen majorly in and around the pelvis or proximal femur. Multiple myeloma, so very well seen. Multiple punched out lesions. One thing you please remember in multiple myeloma, there is no periosteal reaction, and they are seen as a cold spot in bone scan. Please remember this. Multiple cold spots in the bone scan, and there is no periosteal reaction. Multiple punched out lesions, they will generally give either a skull or a pelvis or the vertebra. See here, punched out lesions are there. There is no periosteal reaction anywhere. So these are the hallmarks for multiple myeloma. This again you can see, they will give multiple myeloma spreads all across everywhere and common cause for pathological fractures. Look at this, all the vertebra is involved. Please remember one more thing, disc space is spared. Whenever you are seeing an image of MRI, you should always look for disc space. If the disc space is appearing normal in height, you rule out infection. In multiple vertebrae are involved, there can be secondaries or multiple myeloma. This very well depicts about the destruction, as I was telling. It can be permeative. What you saw in the skull is geographic destruction. There is a limited here and there destruction. Look at this. It is a permeative destruction. It is seen in multiple myeloma, or it can be seen in aggressive primary bone tumors. Metastatic carcinoma. Okay, look at this. All the vertebrae are involved. Intervertebral discs are maintained normal. With that, I come to the end of the today's discussion. because I had highlighted too many MCQs in my past presentation about oncology, so I wanted to highlight more about text so that you will know the basics. Instead of trying to memorize the number of MCQs and answer that, you should know the concept in orthopedic oncology management. Then you can answer many questions. Okay.
Yes, sir.
I think I have time for about 9 minutes. Give me suggestions for the next class. If you have anything, I am following a particular order. If you feel something has to be addressed as a priority, I'll go accordingly. Or I am willing to change the pattern of my presentation also. I've been repeatedly telling this. How many of them are serious about giving a feedback? Or if I will assume that they are happy with the kind of a pattern what I am following. Pattern in a presentation and pattern in the the chapters what I have picked up. Anybody else? I want to hear other boys, other students' voice as well. Hello.
Yes, sir.
I would be happy to interact quite frequently. If there is break in the monotony, probably you will remember and recollect better. Huh? Otherwise, it is always a welcome move to interrupt me. I would never be offended if you can interrupt in between. If you can ask for a repetition as well. Never be, of course, you people are in different stages of the MBBS course. I understand, but my direction, my purpose would be whether it might be too much for you or too little, but this is basic standard you have to meet if you are appearing for the NEET and other exams.
Sure, sir.
Yeah.
What will be the next topic, sir?
Huh?
What will be the next topic, sir?
Okay. Upper limb traumatology.
Okay, sir.
Upper limb traumatology. It is. Do you? Do you think it's a good suggestion if I announce the topic in advance so that if you can read and have a better interaction at the time of the class?
Yes, sir.
Okay. Good. Okay. Please remember, it would be next Wednesday, and the topic would be upper limb traumatology.
Okay, sir.
Right. Anything else?
No, sir.
Who is this? May I know your name?
Sir, Jayashri Hegde.
Okay, good. Where are you from?
Dharwad, sir.
Okay, good. From SDM?
No, sir. MBBS in Bagalkot, sir. Studied MBBS in Bagalkot.
Okay. Good.
Okay, sir.
Okay.
Shall we close?
Yeah?
Students can submit.
I'll stop recording now. At least you can go on. Recording, I'll stop.